Assalamu alaikum. How are you kids? Hope you all are fine and under the blessings of Allah. Today we are going to start with the chapter corticosteroids and antagonists, and this is from your endocrinology. So I am Dr. Mubasherah, as you all know, pharmacology department, Independent University Hospital. So talking about the adrenal gland, you have to revise its anatomy a bit. It has two portions, adrenal medulla and adrenal cortex, and by now we all know that epinephrine and norepinephrine are secreted from adrenal medulla. So the other part of the gland, adrenal cortex, secretes type of hormones which we are going to study today, that are glucocorticoids. So basically we have two kinds of glucocorticoids, or you can say adrenocorticosteroids, mineralocorticoids and glucocorticoids. Now let me tell you the terms first. When you are talking about adrenocorticosteroids, this means you are talking about both of them, mineralocorticoids and glucocorticoids. When you are talking about corticosteroids, again this is same, mineralocorticoid and glucocorticoid. But when you are talking about only glucocorticoid, then this means it's only cortisol or hydrocortisone. So basically what happens, the adrenal cortex releases a large number of steroids into the circulation. Some of these hormones, which we call them glucocorticoids, have important effects on number one, metabolism, and number two, and very major effect on immune function. The other hormone, mineralocorticoids, have principally, the major part is salt retaining activity, and the mineralocorticoid you all know is which one? Aldosterone. The other category of the hormones are called androgenic or estrogenic hormones, and they have androgenic or estrogenic activity. In humans, the natural major glucocorticoid is cortisol, and the natural major mineralocorticoid is aldosterone, and the natural adrenal androgen is DHEA, dehydroepiandrosterone. Adrenal androgens, they play a major part as endogenous precursors of estrogen in women after menopause. Now we will study a bit about the naturally occurring cortisol or hydrocortisone. So we will come to the pharmacokinetics first, where it is synthesized in our body. The cortisol is synthesized from cholesterol. The secretion is controlled by negative feedback through which hormone? ACTH, adrenocorticotropin hormone, and exogenous synthetic glucocorticoids. Means in our body, the secretion of adrenocorticosteroid is controlled by ACTH, and if you are giving from the outside glucocorticoid, synthetic glucocorticoid, then again its secretion will suppress. So another term we will read is corticosteroid binding globulin. What is it? It is an alpha-2 globulin synthesized by the liver, and this binds about 90% of the circulating cortisol. Okay, so in this slide what we have cortisol. Cortisol is synthesized from cholesterol, and its secretion and its amount is controlled by negative feedback. Plus, if you're giving from the outside, then we have CBG, corticosteroid binding globulin. The hormone binds with CBG, and after that it's actions. So how it is synthesized and how it is released? They are synthesized again under the influence of ACTH, and from where ACTH comes? Anterior pituitary. The hypothalamus then releases a hormone called CRH, corticotropin releasing hormone. The CRH then travels directly to the pituitary gland where they cause the release of ACTH. Alright, then ACTH is released into the bloodstream. Once the ACTH comes in the blood, ACTH travels to the adrenal cortex where it affects the release of corticosteroids. So this is how the secretion of corticosteroid is maintained. Now in this figure you can see from the hypothalamus is being secreted what? CRH. Then CRH goes to anterior pituitary. Anterior pituitary secretes ACTH, and ACTH causes the adrenal cortex to secrete corticosteroid. When enough of the corticosteroid is being provided to the body, then this corticosteroid acts as a negative feedback and it inhibits or it suppresses both CRH and ACTH. So, albumin has a large capacity but low affinity for cortisol. Albumin-bound cortisol should be considered free. So, apart from the CBG, cortisol also binds with the albumin but up to very low amount. Synthetic corticosteroids are, as you all know, dexamethasone. They are largely bound to albumin rather than CBG. So here you read the one difference between synthetic and natural. Natural cortisol binds with CBG. Synthetic cortisol binds with albumin. Yes. So the half-life of cortisol in the circulation is normally about 60 to 90 minutes, means more than an hour. Half-life may be increased with few things. If you are giving hydrocortisone from outside, and if the body is experiencing stress, liver disease, or hypothyroidism. Most of the cortisol is metabolized in the liver. About 1/3 of the cortisol produced daily is excreted in the urine as a metabolite as named as dihydroxyketone and is measured as 17-hydroxysterone. In the absence of the stress, this 10 to 20 mg of cortisol is secreted daily. Means if you are stressed, your cortisol will be secreted more. Okay. Coming to the pharmacodynamics, we will read first about the mechanism of action. Before reading the mechanism of action, we will study a bit about the corticosteroid receptors. They are the members of the superfamily of the nuclear receptors, as we all know. And what are the examples? Like steroid, sterol, thyroid, retinoic acid. In the absence of the hormonal ligand, glucocorticoid receptors are primarily cytoplasmic, in complex with the heat shock proteins. What this sentence means, that where are the glucocorticoid receptors? Cytoplasmic. And what complex they form? They form the complex with the heat shock proteins. Now what happens? Free hormone enters the cell, binds to the receptor, induces conformational changes, and these changes allow the hormone to dissociate from the heat shock proteins. This ligand-bound receptor complex is then actively transported into the nucleus where it interacts with the GREs. What are GREs? They are glucocorticoid receptor elements in the promoters of the responsive genes and activate transcription of the target genes. Now you can see this figure, this mechanism of action on your books. The figure is given in your books. So what happens? The free hormone enters the cell, binds to the receptor, forms a complex under the influence of some conformational changes. It forms complex with the heat shock proteins. Then after that it becomes dissociated, and then this ligand bound receptor complex is transported into the nucleus, and then where it reacts with the GREs, and then further transcription of the occur. There are very important physiological effects of the cortisol. As we all know, it has major metabolic consequences of glucocorticoid secretion or administration are due to direct action of these hormones in the cell. Some of the effects are also responsible for homeostatic responses of the insulin and glucagon as well. There are certain permissive effects without which many normal functions become deficient. Now, what do you understand by the permissive effect? For example, let's say the response of the vascular and bronchial smooth muscle to catecholamines is reduced in the absence of cortisol, and it is restored by the physiological amounts of this glucocorticoid. Means if the body is experiencing low amount of cortisol, the response of the vascular bronchial smooth muscle to catecholamines will also be decreased or diminished. This is one example. The other example is lipolytic response of fat cells to catecholamines. ACTH and growth hormones are attenuated in the absence of glucocorticoids. So, what are the physiological effects? Physiological effects are usually mostly on the immune response, on the metabolism, on the fat cells, on catecholamines. So some of the metabolic effects have very important dose related effects on carbohydrate, protein and fat metabolism. So now we will study about its metabolic effect on carbohydrate, protein and fat separately. What else? They stimulate the release of amino acids in the course of muscle catabolism. So this is the catabolic effect of the steroid. What? It causes the muscle breakdown, muscle mass breakdown catabolism. But on the other hand, it stimulates RNA and protein synthesis in the liver, and this effect is anabolic. You all know now what is catabolism and what is anabolic. Other than that, there is increased serum glucose levels, increased insulin and glycogen synthesis. It also affects the uptake of glucose by the muscle cells. It inhibits actually. So what happens? Glycogen synthesis in the fasting state occurs, and this effect is known as anabolic effect in the liver. So here I will give you, if the steroid is causing synthesis of something, then we say it is anabolic, and if it causes the decrease or cut down, then we say it is catabolic. The other things are what happens on the effect of lipase and what it causes, lipolysis. But the increased insulin secretion, as we all know, it also affects insulin and it causes increase in insulin. So the increased insulin secretion stimulates lipogenesis and to lesser degree inhibits lipolysis. So what's going on? On one hand, cortisol is causing lipolysis, but by increasing the insulin secretion, it also causes lipogenesis. So what will be the net effect? What will be the dominating effect? Increase in fat deposition due to insulin's action, and due to combined effect with increased release of fatty acids and cholesterol into the circulation. So what happens? You usually see if some patients are on chronically on steroids, they gain weight. So this is the reason they gain weight, because their body is experiencing deposition. Now when we talk about the catabolic and anti-anabolic effects, we talk about the protein and RNA synthesis which occurs in the liver. This is anabolic. And the other effects in the lymphoid and connective tissue, muscles, peripheral fat and skin, they have different anabolic and catabolic effects. In the muscles, it has catabolic effects. In protein synthesis, this is called anabolic effect. So whenever the glucocorticoid level is increased above the physiological amounts, above the normal amounts, it will lead to decreased muscle mass because of its catabolic effect, and ultimately weakness and thinning of the skin. The other major catabolic effect of the steroids is on the bone, and in the bone what it causes osteoporosis, especially in Cushing syndrome, and impose a major limitation to the long-term use of glucocorticoids. So if we are prescribing glucocorticoids to the patients for long term, we must know that it will ultimately cause osteoporosis, especially in elderly patients. You have to be very, very conscious because of the easygoing fractures. And if you are giving it to the children in their growing age, the steroids can reduce the growth. So you can see some of the catabolic and some of the anabolic effects. The major catabolic effect is on muscle mass, thinning of the skin, and osteoporosis. The major use of steroid nowadays, and as you all know that we are facing this corona pandemic, and now the WHO, the other countries, they all have come to a point that they say now, okay, give dexamethasone, it's life-saving. So why it is life-saving? Because in corona infection, what happens? Massive inflammation, massive cytokine storm even. So what dexamethasone is supposed to do in corona? It reduces inflammation, and it has also immunosuppressive effect. So the major use of steroid in our daily diseases, in our daily ailments, in our daily treatment is anti-inflammatory. So what do you understand by actually what happens in inflammation? It is characterized by extravasation and infiltration of which cells? Leukocytes. What happens in inflammation? There is extravasation and infiltration of leukocytes into the affected tissue. Glucocorticoids, they reduce the manifestations of inflammation by their profound effects on the concentration, distribution, and function of peripheral leukocytes, and they suppress the inflammatory cytokines and chemokines and other mediators of inflammation. So if anyone asks you how steroids act as an anti-inflammatory, so here is the answer. They have profound effect on the concentration, distribution, and function of peripheral leukocytes, number one. Number two, they suppress the inflammatory cytokines, chemokines, and all other mediators of inflammation. So what happens after a single dose of short-acting glucocorticoid? The concentration of the neutrophil in the circulation increases, but lymphocytes, monocytes, eosinophils, and basophils decrease. There is a reason for this thing. Why there is increase in neutrophil? Because of the increased influx of these neutrophils into the blood from the bone marrow. And another effect is their decreased migration of neutrophils from the blood vessels, leading to reduction in the number of cells at the site of inflammation. The other effect is reduction in circulating lymphocytes, monocytes, eosinophils, and basophils. The result of their movement from the vascular bed to lymphoid tissue decreases. This is also the mechanism of action of steroids as anti-inflammatory. We have a macrophage system as well, and the defense system, antigen presenting cells. The glucocorticoids inhibit the function of all these tissue macrophages, and the ability of these cells to respond to antigens and mitogens is reduced. Now, this was the hypothesis. That's why the glucocorticoid was not prescribed in corona in the initial months because we thought that it has anti-antigenic effects and it will cause immunosuppression and it will cause the decreased production of antigens and antibodies. The effect on macrophages is particularly marked and limits their ability to phagocytose and kill microorganisms, and that's why they cannot produce tumor necrosis factor alpha, interleukin 1, metalloproteinases, and plasminogen activator. In regard of inflammatory response, they have certain other effects on two things: phospholipase A2 and cyclooxygenase 2. They inhibit phospholipase A2, thereby they decrease the synthesis of prostaglandins, leukotriene, and platelet activating factor. On the other hand, they reduce the expression of cyclooxygenase 2 in the inflammatory cells, and this also decreases the amount of prostaglandins. Now, what happens? All of these effects cause vasoconstriction when applied directly to the skin, possibly by suppressing mast cell degranulation. Large doses of glucocorticoids, if given, they are associated with the development of peptic ulcer. How? Possibly by again suppressing the local immune response against the infective organism H. pylori. They also promote the fat distribution in the body with the increase of visceral, facial, knuckle, and supraclavicular fat, and this is what we call fat deposition or fat redistribution. They have some effect on the vitamin D, on calcium absorption. They antagonize the effect of vitamin D on calcium absorption. They increase the number of platelets and RBCs. If somebody is experiencing cortisol deficiency, that will result in impaired renal function. Why? Because of the augmented vasopressin secretion and diminished ability to excrete water load. Glucocorticoids have some other important effects on the development of the fetal lungs as well, and this is very important thing, that the fetal cortisol is being produced, and this is responsible for the maturation of the fetal. There are certain important effects of the glucocorticoids on our nervous system as well, and what is it? They causes marked slowing of the alpha rhythm of the EEG, and this causes depression. Increased amounts of glucocorticoids produce behavioral disturbances like insomnia, means neend na aana, euphoria, means you are laughing or you are happy without any reason, and depression. If the glucocorticoids are being given on long time, they suppress the pituitary release of ACTH, growth hormone, thyroid hormone, and luteinizing hormone. So there are certain important effects of the glucocorticoids, and there are certain undesired effects of the glucocorticoids. So if you are in stress, your cortisol level will increase. If your body is producing cortisol more than the normal physiological amount, again this will cause depression. When we talk about the immune system or the antibody system, antigen antibody system, so antibody production can be reduced by only large doses of steroids, although it is unaffected by the moderate doses. Means if you are giving steroids and if you are afraid of its effect of the immunosuppression, then you must know that only large doses causes the antibody production to decrease, but the moderate doses have very negligible effect. Here you can see different organs and glucocorticoids effects, starting from the lung, fetal lung maturation. In CNS, you all know by now, it causes anxiety, memory, depression. In cardiovascular system, it may cause hypertension. In the immune system, it acts as an anti-inflammatory and immunomodulator. In bones, it has catabolic effect, that is osteoporosis. In liver, it has certain anabolic effects, lipid and glucose homeostasis. In skeletal muscle, it has catabolic effect, myopathy. In adipose tissue, it has obesity, lipolysis, lipogenesis predominates, and fat redistribution or fat deposition occurs. So when you are going to write about the major actions on different organs, you can write like this, that glucocorticoid effects on liver is protein catabolism and gluconeogenesis. On cardiovascular is maintenance of the responsiveness to catecholamines. In kidney, it has weak mineralocorticoid activity, and in the immune system, it causes immunosuppression and healing. So up till now we talked about the natural cortisol, natural glucocorticoid. Now in case of internal deficiency, we give glucocorticoids from the outside, and they are all prepared synthetically. So what are the names of synthetic corticosteroids? Cortisone, hydrocortisone, prednisone, methylprednisolone, betamethasone, dexamethasone. The last two ones must be familiar with you. On the other hand, mineralocorticoids, we have two, fludrocortisone and deoxycorticosterone. According to the duration of action, we can classify like this: short to medium acting glucocorticoids, hydrocortisone, cortisone, prednisone, prednisolone, methylprednisolone. Intermediate acting glucocorticoids are triamcinolone, paramethazone 2, and fluprednisolone. Long acting glucocorticoids are betamethasone oral and dexamethasone oral, injectable, topical. Both of the formulations are available. When we talk about the pharmacokinetics of the synthetic corticosteroids, they are given by various routes. We have oral, IM, IV, topical, all preparations available. The hydrocortisone undergoes high first-pass metabolism. The oral bioavailability is high. Both endogenous and therapeutical administered glucocorticoids are bind to CBG, corticosteroid binding globulin. Synthetic steroids have to undergo reduction in liver to active compounds. Then it is metabolized in the liver and excreted in urine. Exogenously administered hydrocortisone has half-life of about 1 or 2 hours. Again, the process is same, the mechanism of action is same. Free hormone from the fluid enters the cell, binds to the receptor. Again, it induces the same conformational changes, and then it dissociates from the heat shock protein. This is the same figure, same mechanism, and same wordings even. The complex then is actively transported into the nucleus, where it interacts with the DNA and nuclear proteins, then after binding to the GREs in the responsive genes, the transcription right away. This is the figure, as you can all see. Starting from the above, you can see CBG and S. S stands for steroid. This complex enters the cell. Steroid then binds with the GR. Here you can see S and GR. Then this enters into the nucleus, SG, and here you can see heat shock proteins dissociate. And then this SGRE complex then starts transcription and messenger RNA, and then the further genes form. So after studying the physiological effects, metabolic effects, we can see the uses of glucocorticoids are similar. Management of inflammatory disorders, and what are those? For example, asthma, inflammatory bowel disease. In certain diseases, they act as immunosuppressants. In autoimmune diseases, congenital defect in steroid synthesis, adrenal insufficiency. What does it mean? That if the adrenal gland is not producing sufficient steroid internally, then we give synthetic corticosteroid. And in the last, as we all read, it is used for fetal lung maturity. We will study a bit about its uses. Autoimmune disorders. Autoimmune disorders are like multiple sclerosis, rheumatoid arthritis, inflammatory bowel disease, ulcerative colitis, psoriasis, eczema. In all these diseases, the corticosteroids suppress the inflammation from autoimmune reactions and also reduce pain, swelling, cramping. In allergies and asthmas, in allergies, it causes the immune system to in which the immune system responds to normally harmless substances, and it causes the anti-allergic effect, like in itching, in redness, hives, rash, sneezing, stuffy runny nose, swelling face, lips or throat, or in case of troubled breathing in case of asthma. And this is one of the reasons that the WHO decided to give dexamethasone in corona patients only who are on ventilators or who have labored breathing, but not to be prescribed to the normal breathing patients. When we talk about adrenal insufficiency, then we have to know what is it. It's a hormonal disorder. What happens? Adrenal glands do not produce enough of the cortisol. So we study its two types of adrenal insufficiency: primary adrenal insufficiency and secondary adrenal insufficiency. What happens in primary? The adrenal glands itself, they are damaged and they cannot produce enough of the hormone cortisol. And in addition to cortisol, there may be a deficiency of aldosterone as well. Then comes the secondary adrenal insufficiency. What happens in this one? It occurs when the pituitary gland has a fault and it fails to produce enough ACTH. As we all read, that ACTH is important for the secretion of cortisol. So if ACTH output is too low, cortisol production drops. Eventually, the adrenal glands can shrink due to the lack of ACTH stimulation. In primary adrenal insufficiency, about 20 to 30 mg of synthetic hydrocortisone must be given daily. In acute adrenocortical insufficiency, large amount of hydrocortisone parenteral means IV is given, plus correction of fluid and electrolyte imbalance. Treatment of the precipitating factors means whatever else is editing its effect, and administration of salt retaining hormone is resumed when the total hydrocortisone dosage has been reduced to 50 mg. Means if you have primary adrenal insufficiency, you are giving 20 to 30. If acute, you are giving 100 mg. And then when you have subsequently reduced the dose up to 50 mg, then you are going to add the salt retention as well. Now this is the condition where we study two diseases related to the cortisol. One is Addison disease and the other is Cushing syndrome. Remember, Addison disease is always due to deficiency, but in Cushing syndrome, as you can see this child, there is fat deposition, right? There is puffy face. So Why there is puffy face, why there is fat deposition? Because the cortisol level is increased, and if the cortisol level is increased, we call it hyperadrenalism or Cushing syndrome. These are some signs and symptoms of the Cushing syndrome. As you can all see, overall, the puffy face and hyperglycemia, CNS irritability, moon face, sodium and fluid retention, and the important thing, you can see the person is experiencing fracture, osteoporosis, and you can see the truncal obesity, the fat deposits on face and the back of the fish. Another very important use of glucocorticoid is for the diagnostic purpose to distinguish the kinds of diseases. It is sometimes necessary to suppress the production of ACTH to identify the source of a particular hormone or to establish whether its production is influenced by the secretion of ACTH or not. So this test, which we do by giving steroid to suppress ACTH, is called dexamethasone suppression test, and it is used for the diagnosis of Cushing syndrome, and it is used to differential diagnose of the depressive psychiatric states as well. What we do, we cause suppression with large doses of dexamethasone, and it will distinguish also the Cushing disease from those with the steroid producing tumors of the adrenal cortex or with the ectopic ACTH syndrome. So what does it mean? We have three scenarios. We have Cushing disease, we have tumor producing adrenal cortex, and we have ectopic ACTH syndrome. So how we will understand, how we will diagnose which one is the one? So we give this test, the dexamethasone suppression test, and there are certain doses which we give, and there is certain time which we give, like 0.5 milligram orally every 6 hours for 2 days. Then this is followed by 2 milligram orally every 6 hours for 2 days, and then the urine is analyzed for the cortisol or its metabolite. This is called Liddell's test. And then there is another method by giving a single dose of 8 milligram at 11 p.m. and then the plasma cortisol is measured at 8 a.m. following day. This suppressant effect of dexamethasone will occur in patients with Cushing disease, and it will cause 50% reduction in hormone levels. Now, what you will infer from the patients in whom suppression does not occur? The ACTH level will be low in the presence of a cortisol producing adrenal tumor. The ACTH levels will also be high with an ectopic ACTH producing tumor. So this is how we distinguish the different diseases by giving the dexamethasone suppression. When you are giving any drug for a long period of time, you will experience the toxic effects. So what are the toxic effects, and after how much time the toxic effects you can see? Usually more than 2 weeks. After 2 weeks, the patients may experience insomnia, behavior changes, peptic ulcers, and sometimes acute pancreatitis as well. Side effects are those of the anabolic effects, increased blood sugar level, which can cause diabetes in these patients, and then the body's ability to absorb calcium decreases, and it also causes osteoporosis. Then, as we all read, there is increased cholesterol and triglyceride levels, increased fat deposition, and increased risk of ulcers and gastritis. If you are prolonging the treatment for longer than 2 weeks, then you can experience the more extensive side effects. The osteoporosis will be very frequent, fragile bones, fractures, hypertension, high blood pressure, diabetes, weight gain, increased vulnerability to infection because of the immunosuppressive effect, cataracts, glaucoma, thinning of the skin, and easy bruising, easy internal hematoma formation. Because of the continuous breakdown of protein and diversion of amino acid to glucose production in the body, there is increased need for insulin, and because of this there is weight gain. Then visceral fat deposition again, myopathy, muscle wasting, thinning of the skin, hyperglycemia, diabetes, eventually osteoporosis, and this all effect is due to continuous breakdown of protein and diversion of amino acids. When given in larger than physiological amounts, we have some mineralocorticoid effects as well. Some sodium and fluid retention occur, and loss of potassium will be experienced. In patients with normal CVS and renal function, this leads to hypokalemic, hypochloremic alkalosis, and a rise in blood pressure. But if the patient is already having heart disease, even if you give a small amount, it will cause sodium retention, fluid retention, and it may lead to heart failure. All these effects can be reduced by using synthetic non-salt retaining steroids. Sodium restriction means you have to give low salt diet and potassium supplement. The other major effect, the side effect or the unwanted effect of giving steroids for more than 2 weeks is adrenal suppression, and also the hypothalamic pituitary adrenal axis suppression occurs. So usually you have heard that if you are going to give corticosteroids and now you want to taper it or you want to stop it, then you will not abruptly stop because of the withdrawal symptoms. Rather, you will first decrease the dose and then you will come to the reduced dose. There are certain special precautions for the patient receiving steroids, like blood sugar level, as they may become diabetic, sodium retention, so electrolytes, as it will cause hypertension, so you have to keep measuring the blood pressure. Because of the potassium loss, you can look for the hypokalemia, peptic ulcer, fractures, osteoporosis, and certain hidden infections. So if you are going to give steroids, the dosage should be kept as low as possible and try to give the steroids on alternate days. Now there are certain contraindications, and always remember contraindication come from their untoward effects. So when we say it causes peptic ulcer, so you will not give in the patients who are already having peptic ulcer or already having heart disease, hypertension, osteoporosis, diabetes, or psychosis. Here up till now we ended with the glucocorticoids. Now we will learn about the mineralocorticoid, and we have the natural mineralocorticoid that is called aldosterone. Aldosterone binds to specific intracellular receptors where in the distal convoluted tubules, and what it causes, it inhibits sodium excretion and it stimulates potassium and hydrogen excretion. So what will be the net effect? Sodium retention and potassium and hydrogen excretion. Synthetic, now we have synthetic mineralocorticoids, deoxycorticosterone acetate. It has many mineralocorticoid effect, and the other very common drug, synthetic mineralocorticoid, is fludrocortisone. It has both of the glucocorticoid and corticoid effects. Coming to the pharmacokinetics, plasma half-life of aldosterone is 20 minutes only. and that of the synthetic corticosteroid is long, 1.5 hours or 1 to 2 hours. Administration is by oral route of the fludrocortisone. We have the adverse effects: hypernatremia, hypervolemia because of the fluid loss, hypokalemic alkalosis because of the potassium loss, and hypertension because of the fluid retention. Therapeutic uses where we give mineralocorticoid or where we give aldosterone in acute adrenal insufficiency and also in chronic adrenal insufficiency Addison's disease. In both cases, this is a very important point, in both cases cortisol must always be given concomitantly. We will read a bit about the aldosterone now, what it do with the blood pressure. When aldosterone is not secreted in the correct amount or in the normal amounts, what body experiences? The body loses too much sodium and retain too much potassium. Having too little sodium in the body causes hyponatremia, and too much potassium lead to hyperkalemia. And when this happens, when we don't have aldosterone. The aldosterone have certain physiological and pharmacological effects on our body. It promotes the, as you all know, it promotes the reabsorption of which salt? Sodium from the distal convoluted tubule of the kidney and from the cortical collecting tubules. Some reabsorption from the sweat and salivary glands also occur from GIT mucosa and across cell membranes in general is also increased. The other important physiological effect is the excretion of potassium and hydrogen ion. The excessive levels of aldosterone lead to hypokalemia, metabolic alkalosis, increased plasma level, and hypertension. Here you can see how this all occurs. Angiotensin causing the release of renin causing the conversion of angiotensinogen 1 to angiotensin 2. Angiotensin 2 causes the release of aldosterone, and aldosterone causes nephron distal tubules to reabsorb more sodium and water, which increases the blood volume. Now, where are the mineralocorticoid receptors? These receptors are present in the cytoplasm of the target cells. Principal cells are distal convoluted tubule cells and collecting tubules of the kidney. The major effect of activation of the aldosterone receptor is increased expression of sodium potassium ATPase and the epithelial sodium. Coming towards the metabolism of the aldosterone, it is secreted at the rate of 100 to 200 microgram per dl in normal individuals with a moderate dietary salt intake. Half-life of aldosterone of the natural aldosterone is 15 to 20 minutes only. The metabolism is similar to that of cortisol. Approximately 5 to 15 is excreted free or as metabolite named as 3-oxoglucose. Now we will read about the synthetic mineralocorticoid, that is fludrocortisone. This is a potent steroid with both of the gluco and mineralo activity. It is the most commonly used, most commonly prescribed mineralocorticoid. Oral doses of 0.1 milligram 2 to 7 times weekly have potent salt retaining activity, and where they are used, fludrocortisone is used in the adrenal insufficiency associated with the mineralocorticoid deficiency. Up till now we read about the hypoaldosteronism. Now we will read about the hyperaldosteronism. If the body is excreting excess of the aldosterone, then what happens? So again, like that of the cortisol, we have primary aldosteronism and secondary. And what happens in primary? There is overproduction of the aldosterone by the adrenal gland, and because of the excessive amount of aldosterone leads to high blood pressure associated with hypokalemia. But in secondary hyperaldosteronism, this is due to the overactivity of the renin-angiotensin system. Means the renin-angiotensin are causing increased secretion of aldosterone. In hypoaldosteronism, an ACTH stimulation test for aldosterone can help in determining the cause of hypoaldosteronism as I described. Up till now, we covered glucocorticoid, natural synthetic, mineralocorticoid, natural synthetic. The glucocorticoids, the natural one is cortisol, the synthetic is prednisolone, dexamethasone, betamethasone. The natural mineralocorticoid is aldosterone. The synthetic mineralocorticoid is fludrocortisone. Now, there are certain drugs which are called adrenal corticosteroid inhibitors. These are the drugs that inhibit the key step in the synthesis of hormones produced by the adrenal cortex, such as you all read now: mineralocorticoid, glucocorticoid, androgen, and estrogens. What they do, they block one or more key enzyme in the steroid synthesis. They are used in the Cushing syndrome, where there is excessive amount of cortisol, and in other types of adrenal cancers. So here, this is the figure which is given in your books as well. Here you can see the agonist and antagonist. Agonist you all know by now, so now we are going to read about antagonist. So the antagonism is at two levels. One is at the receptor level and the other is at the synthesis level. So we have receptor antagonist, glucocorticoid antagonist, mifepristone, and mineralocorticoid antagonist, that is spironolactone. Spironolactone you have read in the diuretics. So we will read about the mifepristone. This is a glucocorticoid receptor antagonist. So as the name indicates, it causes the receptor to bind with the aldosterone and has occasionally been used in refractory Cushing syndrome, and it is a approved treatment for the control of hyperglycemia associated with the syndrome. The other one is the metirapone, and this is the inhibitor of glucocorticoid synthesis. And what is the mechanism of action? This is the synthesis inhibitor, so it will decrease the effect of or stops the key enzyme 11 beta hydroxylase, which interferes with the cortisol and corticosterone synthesis. In the normal pituitary gland, there is compensatory increase in this cortisol secretion. This response is a measure of the capacity of the anterior pituitary to produce ACTH. So when you will give, what is the indication? Diagnostic test of the pituitary function. What is the use of metirapone? It is used as the diagnostic test of the pituitary function and may be useful for reducing cortisol production to normal levels in Cushing syndrome. The aldosterone antagonist or the mineralocorticoid antagonist is spironolactone, and this one you have read in the diuretic section. This is an aldosterone antagonist. It is a diuretic and it antagonizes the action of aldosterone at the mineralocorticoid receptors. This is often used as an adjunctive therapy in combination with other drugs for the management of chronic heart failure. Spironolactone is the name.